Welcome back to another edition of the Citizens Fire Academy on Channel 18. And today we're going to talk about EMS, or Emergency Medical Services. And that's a big part of our job in what we do on a daily basis. And I'm here today with Rob Sanders, who's the EMS Officer here at the Fire Department. And welcome, Rob.
Thank you.
And before we get started into what's involved in you being the EMS Officer, how'd you get started in the fire service?
Well, like most folks in this line of work, it was simply through exposure. My mother was a retired nurse from Cape Cod Hospital. Had several relatives in the fire service, police officers, canine officers. So just a matter of exposure, and really kind of got my appetite going, if you will. While I was in college, I took a job at Nickerson State Park as a ranger for 4 summers. And that really kind of solidified my my commitment to keep going forward with public safety.
As being the EMS officer, what are the main roles that and responsibilities that you have?
Well, like most EMS officers throughout the Commonwealth of Massachusetts, it's a variety of roles and responsibilities, which has grown over the years because the demands and requirements have increased both at the state and the federal level. But to give you some examples, maintenance of equipment, I coordinate all the training requirements here at the fire department for EMTs at all levels, protocol changes, medication changes. I also act as a liaison for various regional agencies, state, federal government, represent the department on several boards. And also QA/QI has become a very important and time-consuming role in the last 4 or 5 years. EMS is heavily regulated, and as the regulations change and the requirements change, we have to react with it.
Let me ask you, QA and QI, for probably what the folks at home don't know what that is. What does that mean?
Well, like other businesses,
what's the QA stand for and QI stand for?
Quality assurance, quality improvement. And like most businesses who do QA/QI, EMS essentially is no different. So how do we achieve that? Run review is a big portion of it. So I review by regulation a certain amount of runs, certain types of calls that we get. I also, the region reviews the call runs also, and they send me a package every month, which I have to review. So it's primarily through run review that we achieve QA/QI.
Okay, probably a common question would be, what's the difference between an EMT basic and an EMT paramedic?
First of all, let me start off with what is essentially both categories of EMTs perform at any level, and that is you're trained to secure the scene, do primary patient assessment, provide emergency medical care in the nature of any life-saving procedures, breathing for somebody, CPR, defibrillation, provide certain medications that can be done, something called point of entry, which is essentially determining what's the appropriate facility the patients to be transported to. And EMTs at all levels are trained to that. What separates an EMT basic from an EMT paramedic are a few things. One is the depth of knowledge. Paramedics have much more training in the depth of certain disciplines in EMS. Also, they're trained in specific skills that EMT basics can't do, specialty skills, specialty areas, and also medications. We have over 50 medications that we're authorized to carry on the trucks. So that's some of the differences between the two. I might also add that the term EMT basic is really not appropriate anymore, because the EMT basics now really do advanced skills. There's about 5 or 6 medications, as you know, that EMT basics can administer on their own within the protocols and guidelines, without a paramedic being there, without permission or need to call the physician.
A final question before you get into a little bit of show and tell. Schooling, length of schooling for an EMT versus a paramedic.
Excuse me. We have to be an EMT basic first before you go to paramedic school. Depending on the type of program, most EMTB schools are about 3 to 5 months in length. And they don't anymore require any hospital time. That is an option right now. Some programs will take the EMT basics and send them to the emergency room for a day or so. On the initial training to carry it over to the paramedic side of things, that's most programs, it's a full year, virtually around the clock of commitment. As most paramedics who've gone through it will tell you, it's very similar to physicians going through medical school. If they're not in class or doing practical skills, they have to do over 1,000 hours of clinical time in the hospital. So they'll be in rotations in the emergency room, the operating room, and so forth. So that's for the initial certification.
Okay. Why don't we take a look inside the ambulance and show us around a bit?
First of all, I want to follow up with earlier when I was mentioning about training for EMT basics and paramedics. To follow up with that, once we get our certification, our license is good for approximately 2 years, and within that 2-year time period, there's a certain amount of training that EMT basics and paramedics have to achieve. And actually, the Con Ed requirements are greater than nurses and physicians. Part of that training is familiarizing ourselves with what we call the treatment protocols. Ambulance services in the Commonwealth of Massachusetts are regulated. We come under the Department of Public Health, Office of Emergency Medical Services. So they come out and really dictate treatment protocols, what certain medications we can use, what treatments, and also whether we can do them on our own or whether we need to call permission. Doing a procedure on our own is called standing orders, and then if we need permission, it's called requesting medical control. Over the years, I've been here paramedic, almost 27 years. We were calling for permission for quite a few things back then. Over the years, it's referred to as the Mother May I line has changed drastically. So paramedics and EMTs are authorized to do quite a bit on their own before they have to call and get permission from the physician. So what I'm holding here in my hand is our treatment protocol book, and this is updated every year. And as you can see, it's quite thick. And it covers an introduction to generalizations on how we are to treat and transport patients, okay? And also specifies in each discipline, whether it's cardiac, trauma, respiratory, again, what EMTs can do, what paramedics can do. Okay. Carrying on over here, I want to touch a little bit about our communication system. We run what we call a paramedic basic system here, and the state of Massachusetts, the regulations actually recently changed. Services have a choice. You can run 2 paramedics all the time, or you can run a paramedic basic service. Which each category, there are certain items that are in the regulations that you have to follow. So basically here at the town of Harwich, we run a PB, a paramedic basic system, which means that paramedic and basic are always on the truck. And then for the higher priority calls, we will call in additional paramedics if needed. In order to have an ALS license in the Commonwealth of Massachusetts, you have to have the ability, if needed, to have direct communication with the ER physician. So we do that by having a radio on the truck and a system called CMED, Centralized Emergency Medical Dispatch. So we have to talk to the hospital, whether we're going to just notifying them that we're bringing somebody in, or we actually need to get orders from the physician. We would pick up this radio here, and it goes to a centralized location. And on Cape Cod, it's at the Massachusetts Military Reservation at the Barnstable County Communications Center. Then they would give us, call in on Channel 4. All ambulances call on that. And then depending on radio traffic, there are over 50 ambulances on Cape Cod. And only 2 hospitals. And at Cape Cod Hospital, the emergency room charge nurse who was answering this, there's only 1 radio. So you can imagine on a busy day in July, it gets very, very busy. So what we do is called radio triage. Triage is a French word meaning to sort out. So the ambulances call into the dispatcher, and we categorize them as priority 1, 2, or 3, depending on the severity of the patient. And then we essentially get in line and wait. And obviously, the higher priority calls get patched to the hospital first. So there are times when it gets very busy. If we have a low priority patient, we could be waiting, 10, 15 minutes sometimes in the hospital. And occasionally, things really busy and a low priority call, we don't get patched at all. They will just call a hospital and say, Harwich is coming in with whatever we have. They'll be there in 10 minutes, simply because the ER is so busy. Cape Cod Hospital, ER is the busiest emergency room in New England 4 months of the year. And a large majority of those patients are transported by rescue services. About 2 or 3 years ago, we went from paper medical reports to electronic. And this is the computer system we use here. It's called AmbiPro. There are others out there on the market. So each ambulance, we have 3 ambulances in town. And each ambulance, and actually both engines, have a computer system in it. So our reports are written on here, and when we get to the hospital, we make copies of them. The hospital scans them, and then it's permanently put into the patient's record. I want to show you here, give you an example of how many medications we carry. We split our medications into really 2 sections on 2 storing areas on the truck, 2 areas of storage. One is the bulk of the medications where we feel we probably will not give out in the house or in the street, and we carry on the truck. So this is an example right here, and we carry over 50 medications. And again, some of these medications EMT Basics can also use. We have a smaller medication module here. This has majority of our frontline medications that we would need to give in certain scenarios, either in the house or out in the street. And we'll sweep over here to my left. This is our cardiac monitor. This is made by Physio Control. Per the regulations, for an ambulance to be licensed as an ALS, Advanced Life Support Truck, you have to have the ability to do 12 lead EKGs. 12 leads simply means you have to be able to do 12 views of the heart. And this is used in us attempting to classify whether the chest pain is cardiac in origin or not. So this machine does many functions. It'll do 12 lead EKG. It'll also defibrillate. That is an electrical charge given to the heart when somebody goes into cardiac arrest. We can monitor a whole array of other functions with this. And each ambulance has one of these devices. One of the skills that we do routinely with patients is start an IV. IV means intravenous. There's a couple of reasons we would do that. One is to have access to give fluids, such as, for example, what I'm holding up here. This is sodium chloride. This is what we carry on the trucks. And this fluid is really a natural compound that we already have to some degree in our bloodstream. So we would start an IV, hook up tubing to the bottom here, and enter the vein with a needle. Actually, the needle comes out, and there's a little plastic catheter that stays in. So we start IVs, as I said before, for a couple of reasons. One, to replace fluids in the case of fluid loss or blood loss, and also has a very important means to give medication. When we give medication IV, it gets on board very quickly, and it acts on the whole body system much more quicker than if we gave it intramuscular, like you would receive your flu shot. So this is a skill that paramedics are quite proficient at, and we do this almost in every patient. I also would mention that a lot of the medications and procedures, including starting IV fluids, are, if we did not perform them, they would be done in the emergency room. This ambulance is really an emergency room on wheels. And for the most part, outside of a few really specialty procedures that ER physicians can perform, really the first 10 to 15 minutes of any emergency, the medication, the procedure can be done back here in the ambulance. So what does that mean for patient care? When things get done quicker and faster, hopefully the patient will respond better. Sometimes it reduces hospital stay, reduces ER time. In fact, it's to the point now where the emergency room is so busy that if we don't perform these procedures, that means the ER nurse has to do them. And if they're not done, they usually give us a kind of a dirty look, like, why didn't you do this? So it really is an emergency room on wheels, and we're taking the ER out to the street, if you will. To finish up our inside tour of the ambulance, the storage cabinets here, I'll just touch on a few items here. And we really have to be prepared for anything, any type of call, from hazardous materials to cardiac to drownings to childbirth. So we really are well stocked to take care of the early part of really any emergency. So in here we have our OB kits, our birth kits, some hazardous materials, protective gear here. And going down here, this is primarily our trauma cabinet. Trauma being a physical force applied to the body. Somebody shot, stabbed, or motor vehicle accident, falling out of a tree. And we have different size bandages here. I will call your attention to a fairly new device bandage that we're allowed to carry on the trucks, and this is called Quick Clot. With trauma patients who are losing blood, it's very important. So one of the first steps to do is to stop the bleeding. Sometimes direct pressure by bandages is not enough. So these bandages now are impregnated with a chemical that acts to coagulate or stop the bleeding, and we're allowed to carry them on the trucks. In addition to that, we also have this cabinet up here is kind of for our specialty procedures, if you will. One of them is starting IVs. We usually go in the arm or a vein in the hand. Sometimes if it's life-threatening and we can't get an IV in, there's a new procedure for us. It's been around since World War II called intraosseous, which means we take a drill. And here's the kit right here, and really it looks like a screwdriver drill, and we take an IV needle in it and actually drill into the bone and give fluids and medications that way. It sounds a little painful, but we do give some medication before that. And again, that's only in life-threatening scenarios where we can't get an IV. That's one example, again, of the specialty skills that really have evolved over the last 5, 10, 15 years or so. Over here is our cabinet for our equipment, what we're going to take into the street or into the house. How much we bring into the house or out in the woods or on the bike trail is really a judgment call on the paramedic. And to finish off with our section on EMS here, I wanted to add on another capability of the EMTs and paramedics, actually in the Commonwealth of Massachusetts, and the way the protocols are set up. In the last few years, medical care has evolved in what we call point of entry centers. And what I mean by that now is for certain disciplines, for certain illnesses, the medical community at large, national organization, have decided for the best care of the patient, they need to go to a specific facility. So, for instance, strokes. If we suspect somebody is having a stroke, okay, they have to go to, by regulation, a certified stroke center. Cape Cod Hospital is a certified stroke center. Right, so if you were working in ambulance in a different part of the state and you had your choice between two hospitals to go to equal distance or even not equal distance, and somebody was having a stroke and one was not a stroke center, you would go to the stroke center. So the primary three right now: strokes, cardiac events when you suspect a heart attack, and 3, trauma. I already mentioned the stroke point of entry. The cardiac point of entry now is patients who you suspect are having a heart attack. And I mentioned before, we use the 12 lead capability we have to pretty much to determine if we're going to go that road. Cape Cod Hospital actually is a very famous cardiac cath center. They have some of the best times and reperfusion times literally in the world. So for Cape Cod Hospital, for us that covers a stroke center, a cardiac center. Last point of entry I want to talk about is trauma. And fairly recently, the state of Massachusetts is really been comprehensive in incorporating a statewide trauma system. So what does that mean for the patient who's fallen out of a tree or in a motor vehicle accident? We have guidelines actually from the CDC and American College of Surgeons that the state has adopted that if you meet certain criteria, very specific things that we see in the patient, they're designated now to go to a trauma center, either a level 1 or a level 2. Again, this is by regulation, so we have to follow the regulations. This is one area where Cape Cod Hospital currently is not a trauma center. So for this part of the Cape, let me back up for a second. The closest trauma center before going to Boston is South Shore Hospital in Weymouth. They're a level 2. They've been one for about 4 years. So services up in the Upper Cape, say from Barnstable towards the bridge, there actually is a line on a map they came up with that if you're over that line, you really have two choices. You can call for the helicopter, Boston Med Flight, or if you feel it's faster or the helicopter's unavailable, then you would actually go off Cape to a trauma center. And that's a big change for us down here. From, say, Dennis and Harwich down towards P-Town, we primarily, if they meet the criteria for trauma center, we will call for Boston Med Flight. And again, EMT Basics can make that determination on their own. If the helicopter is unavailable, most of the time we're going to go to Cape Cod Hospital. So that ends the tour of the ambulance and my presentation on EMS and Harwich Fire Department. Again, my name is Rob Sanders. I'm the EMS officer here. If you have any questions or want to come up and get a more personalized tour, please call the fire station and leave me a message. I'll be glad to meet with you. Thank you.
What we're going to do now is give you a behind-the-scenes look at a typical medical call that we would respond to. And the one today is going to involve chest pain. And I'm going to let Rob describe for you what you're going to see. Rob?
Thanks, Captain Clark. Chest pain is quite one of our more frequent calls that we go on. And during the initial assessment of the patient, one thing we're looking for is to try to get an idea of the cause of the chest pain. If it is cardiac related, there are certain things that we look at. Wanted to see if it is indeed a heart attack. What is the definition of a heart attack? A heart attack is most often caused by a blockage of a coronary artery, therefore stopping blood flow to a certain part of the heart. If the blood flow is stopped for a certain length of time, that part of the heart dies, and essentially that part of the heart will stay dead forever. So this is, here you see an illustration of a coronary artery and the plaque buildup, thereby causing a blockage. So wherever the blockage is, right here under my finger, anything south of that is blocked. So that part of the heart is not receiving any oxygen at all. So there are certain things we look for on an EKG. An EKG is an electrocardiogram. It measures the electricity that the heart is producing. And we put slang term is stickies on the chest, referred to as leads. Paramedics several years ago were now trained to recognize and read 12-lead EKGs. So what that simply means is a lead is a viewpoint of the heart. It's like a camera on the outside going around the heart. So 12 lead means 12 viewpoints of the heart. So certain things we look at that are indicators to us that indeed it is a heart attack, or otherwise known as myocardial infarction, and there is a blockage in place. In addition to the treatment that we would do in the ambulance, certain medications we would give, we would also give early notification to Cape Cod Hospital and possibly activate what is called the cath lab. The current preferred treatment for unclogging a blocked artery is catheterization. And what they do at the cath lab is they insert a catheter up through the groin into the heart. Okay, and the cardiologist or the interventionist, they're trained, this is a cardiac specialty. The balloon would then enter the area of the blockage and inflate, opening up the area, reperfusing blood flow, and then preventing essential death of that tissue. Frequently after they inflate the balloon, they place what is called a stent to keep the artery open. And I have a couple examples here. And this is, when they do this, they shoot dye to see if the balloon has worked. And they take actually a video of it and stills. So right here you have this artery. I don't remember which one it is. And you can see it's 100% occluded because you should be able to see dye flowing all the way down in the other distal section of the heart. All right, so after reopening the balloon therapy, you could see a great reperfusion, okay, to the heart. This is called, referred to as door-to-balloon time. The Heart Association national standard is from the time the patient enters the door of the hospital, if they are having a heart attack caused by a blockage, right, the standard is that they should be opened up. The balloon should be inflated within 90 minutes. Cape Cod Hospital literally has the world's record for door-to-balloon times, some in the area of 20 to 30 minutes. Why is this important? Why is it important that paramedics recognize this early and transport to cath lab? The saying is time is muscle. The sooner we get to the cath lab, the sooner they reperfuse, okay, the sooner we could save heart muscle from dying. Geez, Captain Clark, after all this interview and talking and been a rough day at the EMS office here. I don't know. I'm not feeling so good. Hold on a second. I gotta sit down. I think we'll have to end my interview right now. I'm not feeling too good. Ugh.
Hello, sir. My name is Justine. What's going on today?
I got chest pain about 5-10 minutes ago.
Okay. I'm going to feel your pulse here just while we talk. So what were you doing when the chest pain came on?
I just walked in the community center just to check the schedule for the exercise room, and initially I thought it blew it off. I tried different positions, but nothing's relieved it.
Okay.
So I just thought I didn't want to call, but they called for me. So
well, it was a good thing you called. Joe's going to take your vitals. He's going to take your blood pressure, and Justin is going to put on the cardiac monitor. It goes on each arm and each leg. It doesn't hurt. It's just stickies.
Okay.
So while they do that, I'm going to ask you a few questions. Tell me about the pain.
It's real tight. It feels like somebody's sitting on my chest, actually squeezing.
Has this ever happened to you before?
No, never.
Okay, so you don't take any medicine for heart?
No, I'm healthy. I just had a physical last week. Everything was fine. That's why this is really.
Did you get nauseous?
Scared. No, not at all.
Did you get sweaty?
A little bit, yeah, I did.
So does it stay in your chest? Does it change when you move?
It doesn't change when I move at all.
Take a deep breath for me. Does it change when you take a deep breath?
Nope, that's fine.
Okay.
Nope.
All these things that we're doing here, we're just going to get a quick baseline of your vitals. Anybody who has chest pain, we always suggest that they go up to the hospital.
You really think I need to?
I do.
Folks can't, let me know right here, then make a decision. No, I really should go.
There's only certain things that we can do. The hospital can do a lot more diagnostics, one of them being checking your blood. If you are having a cardiac problem, like a heart attack, your heart actually puts out an enzyme that they can check in your blood. And that's something they can only do at the hospital. So it's best that we go get that checked out.
Okay. All right. I'll agree to go. Yeah.
Blood pressure.
Okay. So your blood pressure is a little bit high, but that's normal because you're nervous and you're in some pain. On the monitor, it looks normal right now. So that's all good. When we get in the ambulance, we're going to put a little bit more heart stickies on you. They go on your chest.
Okay.
Okay.
But if it looks all right now, though, do you
Because
still think I need to go?
Absolutely. Like I said, we're not doctors. We're not supposed to diagnose. We're
Okay.
just supposed to
Okay.
treat the patient. And right now you're having chest pain, and we can take care of that for you.
Okay.
So what we would like you to do is stand up. Just this little movement. Does your chest pain change at all?
Nope.
Nope.
No.
Okay,
No
good.
movement at all. It's pretty steady. Real tight.
So if 0 was no pain and 10 was the worst pain you've ever had, what number could you give this? I know it's a silly question, but it's
about
a
a-
good baseline for us.
I don't know. Maybe a 6.
Okay.
A bunch of seatbelts here.
Yeah, it hasn't let up. It started off as a 6. It hasn't changed
And this
at
has
all.
never happened to you
No,
before.
never. No.
What medicines do you take?
I don't take any.
No, so no high
I
cholesterol.
run. I lift. No, nothing. That's what really caught me off guard.
Any family history?
Not that I'm aware of.
Okay.
No.
That's all good. How about allergies to medicines?
No. No
Shellfish?
allergies. No.
Iodine?
I eat clams and lobster. No problems at all.
We're going to ask some of the same questions over and over, but that sometimes if this is the beginning of a heart attack, if we ask the question over and over, things may change, and then it gives us a good indication that,
Okay.
okay?
All right.
You ready
sure.
to go?
Okay.
When we get in the ambulance, we're going to do a few more things. Like I said, put the 12 lead on you, start an IV, put you on some oxygen.
Okay.
Okay?
All right. Very good.
Ready?
Mr. Sanders, it looked like you were starting to get a little anxious. Did your chest pain change or get worse at all?
Yeah, a little. It's starting to get a little worse.
You said it was a 6 on the pain scale. Is it higher than that now?
Maybe an 8. Yeah, it hasn't subsided at all. Yeah, it's still a tight squeeze.
Okay, this is what we're going to do. We're going to do a few things all at once, so not to scare you, but we're going to put you on some oxygen. It goes in your nose. It's called the nasal cannula. We're going to start an IV, and we're going to put you on the cardiac monitor on a 12 lead. It gets a better look at your heart. Do you have any questions?
Yeah. What do you mean by 12 lead? I don't understand. What does that mean?
Originally inside the house or the community center, we put you on something that's called limb leads. It just gets a quick look at your heart. The 12 lead actually looks at more angles of your heart.
Oh, okay.
That's all. So we can get a better picture. Okay. While we're doing this, I'm going to get 2 baby aspirin. They're chewable, so you can swallow them. You don't need anything to drink with it. What the baby aspirin does is if you are having a cardiac event or a heart attack and one of your vessels is clogged, the aspirin actually helps stop the block process. So I'm going to put this in your hand,
Okay.
and you need to chew them and swallow them.
Okay.
Okay. So what Joe has done is he spiked the bag. That's just normal saline. It's something that our bodies make naturally. That's the closest thing that science could get to that. And right now Joe's on the computer. He's entering in Mr. Sanders' personal information. We may ask him questions like, what's your social security number, Mr. Sanders?
010-560530.
And that comes in handy at the hospital. It seems like a silly question, but the hospital can pull up all Mr. Sanders' records just by entering in his social security number. So, Mr. Sanders, Justin is going to shave your chest. We have to get our cardiac monitor. Electrodes are sticky. They're sticky, so we have to get the hair off your chest. Sorry about that.
That's okay. It'll grow back.
Are you all done chewing that aspirin?
Yes, that's gone. Yeah, asthma's gone.
Okay. So do you have any allergies to medicines? I know I asked you that inside the community center.
Not that I'm aware of. No,
So no shellfish, no iodine.
no.
The reason why we ask that is when we start IVs, a solution that we use is iodine-based, and it's got some shellfish products in it. We don't want you to have an allergic reaction.
Well, that's good. We want that.
Getting more anxious.
Scared. Yeah, this is.
Yep, so we're going to move a little bit fast here, and actually we're going to do all this while we're en route to the hospital. The best place for somebody who we suspect is having a heart attack is at the hospital. There's that saying, time is muscle, and your heart is made of muscle. So right now Justin's attaching the 12 leads, and all this will be done while en route to the hospital. Most likely the IV will be started en route to the hospital also.
If I am having a heart attack, what exactly will the hospital do?
Once we get a picture of your heart here with this 12 lead, we'll be able to get a quick diagnostic look and determine whether we need to activate something called the cath lab, the catheterization lab. If you're having a heart attack and one of your vessels is blocked, they do a catheterization up through that vessel and they open it, and it actually will get blood to that part of the heart.
Okay. Is this the best treatment for a heart attack? I've seen this in the news, but is this really the best treatment for a blocked artery?
It is the treatment.
Okay, that's good. Sure.
Do you have any questions?
No, that was it.
Okay, so we're gonna do that IV line that she's talked about, okay? Oops, sorry.
What Justin's doing is he's putting a tourniquet on Mr. Sanders' arm. It actually gets him a better view of the vein. Mr. Sanders is on oxygen. We have him on the cardiac monitor. We've gotten his information in the computer. We've given him 2 baby aspirin. The next thing the treatment that we would do is nitroglycerin underneath the tongue, and it actually dissolves. You don't chew it. And what the nitroglycerin will do is open up the blood vessels to the heart. So if there is a blockage, it'll get more blood past the blockage and keep the heart from actually infarcting and hopefully not having any heart muscle that dies.
All set? Swallow?
Okay, the IV's in.
Okay, Mr. Sanders, I'm noticing on your 12 lead that it looks like you could possibly having a heart attack. What we are trained to look at is, yep, I'm just being honest with you, so that's why we're doing all this kind of quickly. So what we're going to give you now is a nitroglycerin, like I just described a second ago, and that will help open up the arteries and the vessels of your heart and get some blood flowing past that blockage. The other things we're going to do is we're going to put these things called multi-purpose pads on you. If for some reason your heart attack gets worse en route and you were to go unconscious and actually your heart would stop, these multi-purpose pads will help us start your heart again. Okay?
That's good. Plan for everything.
So I'm going to do that while Justin actually calls the hospital. We need to contact the hospital and give a radio report and actually activate the catheterization lab.
How quickly will I go to the cath lab once I get to the hospital?
That's the great thing about Cape Cod Hospital and our catheterization lab. Us calling ahead of time, they can actually be in the emergency room waiting for us. So you'd stay right on our stretcher, just get evaluated quickly by the ER doctor and the cardiac doctor and brought right from there into the cath lab.
Okay, thank you.
There's a couple of things that we need to know before I call in the hospital. After we've given you the nitroglycerin and the aspirin, are you feeling any relief from the pain at all?
No.
None at all?
Still at 8 out of 10.
Okay.
It's real tight, no.
Okay, so we'll give you a couple of more of the nitro sprays on the way into the hospital, and we'll reassess your vital signs on the way in. You need to let us know if anything gets better or worse on the way in. Okay?
Okay.
You said anterior?
No, he's having like the Widowmaker, the big one, in the V leads.
Okay.
I'm not going to take that on you.
CMed from Harwich 354. And a priority 1 cath lab activation, please.
I'm not going to put that other one on.
354 is on channel 5.
Yes. And like I said, what that was.
CCH, this is Paramedic White in Harwich 354. We're 20 minutes out en route with a 53-year-old male patient called this afternoon for chest pain. On our arrival, we found the patient alert and oriented ×3. He was pale and slightly diaphoretic, stating that he had a sudden onset of chest pain just shortly after entering the community center. Patient has no medical history, takes no medications, and has no allergies. Patient stated that the pain is a tightness in his chest at a 6 on a 10 scale initially. After we got him into the ambulance, is now up to an 8 on a 10. Got him on the monitor. He's showing a sinus rhythm at 90 beats a minute. His blood pressure is 160 over 100. 12 leads shows that he's having an anterior MI with ST elevation and V2, 3, and 4. He's received 2 baby aspirin and 3 nitro sprays with no relief of the pain. He has an IV saline established KVO. At this point, we are about 20 minutes out requesting the cath lab be activated. Do you have any orders or any questions? Okay, we'll update you with any changes and see you in about 15 to 20.
Mr. Sanders, did you get relief from the nitro spray?
None at all. It's still an 8 out of a 10. Boy, I hope they're ready at the cath. I'm really scared.
Okay. This is normal. The anxiousness, this is all normal. I know it doesn't really make you feel better right at this time, but we're doing everything that we possibly can do. I'm going to give it 5 minutes, and I can give you another nitro. We can do this up to 3 times, and we can also give you some medicine for the pain. It might also help you with your anxiousness.
Okay.
Okay? Any questions?
No, you folks have been great. Thank you.
So en route, we'll check vitals a couple more times after the nitro, and we do that to make sure that his blood pressure doesn't drop below 100. And we just keep on reevaluating, make sure everything is all set for when we get to the hospital for the cath lab.
I'm here with firefighter paramedic Justine Willors and firefighter EMT Joe Rigo, who were part of the crew that was on the rescue call at the community center that you just saw. And the third attendant is firefighter paramedic Justin White, and he isn't here today. He's in a training session, and we'll meet him a little bit later. But I want to introduce to you both Justine and Joe, and just give you a little bio of their background and how they entered the fire service. Joe, what got you interested in the fire service, and how did you end up with us here in Harwich?
I started in the fire service around 2001. I met an old fire captain in a local neighborhood around here, and just talked to him and struck up an interest. And I went to college, got a 4-year degree in fire science, loved it. Worked for a couple fire departments part-time. Then when I graduated, I worked in the town of Nantucket full-time, 3 years, and tried my hardest to get on the Harwich Fire Department. I did that in 2008, and having a ball, love it, love my work, and been doing that, and will do that until late in my life. That's how.
What's the best part of the job?
I love helping people. I love different situations. Put those two things together. You mean go into a bad situation and come out when somebody feels great, they feel confident that they were helped, and things are on an even plane. I enjoy that.
Okay, thanks, Joe. Switch microphones. Justine, same question. What got you interested in the fire service?
I watched a friend of mine go through a fire service training program in Washington State, watched for about 2 years, and realized it's something that I really wanted to do. So I started that in 1993, moved back here to the Cape in 95, got my training here, went to get my medic in 96, and I got hired here in Harwich in 2000.
What's, on the flip side of the coin, the most difficult part of the job?
The most difficult is actually the human emotion. When we go to a high probability, a call where somebody could be fatal and there's family members around, dealing with the human emotion and taking the best care of your patient and making everybody feel like they've been attended to and that we're doing the best job possible.
Probably a common question for somebody on the outside looking in the scenario that we had with the chest pain call, and you show up with a couple of partners, who decides who does what?
Usually on the way to a call, we kind of strike up a conversation in the ambulance who's going to be the lead medic. And if it's a real high priority call, maybe like a car accident or trauma, we'll do things en route, like we'll spike the IV bag, we'll have a conversation, you grab the monitor, you grab the backboard. So we have an action plan and we just communicate en route to the call.
Okay. That's just an introduction of some of the men and women of the Harwich Fire Department, and as the program proceeds, and we're filming it live. And that's one of about 4,000 calls a year that we do here in Harwich. But as the program proceeds, we'll meet more of the men and women of the Harwich Fire Department. And on a final note here, I think what we'd like to do is find out how that patient actually made out who was suffering from that cardiac event at the community center. Rob, how did you make out? What was the final outcome of your event?
Well, thanks to the outstanding care of the men and women of the Harwich Fire Department, I made out great. I was diagnosed at the hospital as having a heart attack, blockage in the heart. I stayed on the ambulance stretcher and went right to the cath lab, as we talked about earlier. Dr. Zellman happened to be there and put a catheter in, balloon, opens up my artery, and placed a stent, which is, he explained, was a scaffolding to hold the artery open, and told me to exercise more and not eat peanuts as often. He also mentioned that it was no damage to the heart at all. And as he mentioned, the early recognition in the field from the paramedics, early transport and early notification of the cath lab, as he said, time is muscle. So there's very little time wasted. From the time I went through the door at the hospital, time they opened the balloon was 40 minutes. I was only there 2 days and had no damage at all. So I made out very well.
Well, that's good news. We can still keep you on here and as your role as EMS Officer of the Harwich Fire Department. And this concludes this session of EMS, and I want to thank you for watching, and see you next time.